I think all the speakers have done justice to the topic. It is very elaborately discussed. There was a technical glitch, no issue. Now, there is one thing that I would ask, anyone can answer that question. Now, regarding the necessity of coronary angiography and revascularization, whether it's a case of HFpEF or it's a case of HFrEF, do we really want to go for an angiography unless the patient complains of chest pain or there is any past history of chest pain? So, what is the present recommendation and what you would like to do in this particular case as far as this
For
coronary evaluation is concerned?
for patients with HFrEF, if you are dealing with a patient with HFrEF, it is prudent to go for a coronary angiogram. But in HFpEF patients, there is no definite indication of doing a coronary angiogram when we are dealing
Right.
with HFpEF patient. For HFrEF, a coronary angiogram should be done.
No,
In
no,
there,
it is prudent. That means, do you mean it's a class one or you
A
may
class
do
2A
because
recommendation is there for
yes,
to do a
exactly.
coronary
So this
angiogram for
it's not
HFrEF
there's no
patient.
compulsion as such,
No,
right?
there is no
Okay.
compulsion, sir.
Good.
For
Okay.
HFpEF, if we are suspecting
Yeah.
the coronary disease is causing the
Yeah,
HFpEF, then only it is a class 2A recommendation. Otherwise, it is
Right.
not.
Okay. Okay. So I don't think that there are any other questions in the chat box. So if anyone else would like to raise any questions, or we are
Yes.
going to pass on to the next session. Okay. Are there any questions
I
in the
think
chat box?
there is one question. There's
Can I
one
comment
question
here?
in the chat box from Bibi
Yeah.
Pandey. In HCM patient with atrial fibrillation, fast ventricular rate, and also has heart failure, how to treat the AF?
Right. Okay.
This is the clinical context that patient given to us, actually, how to treat them. So atrial fibrillation, here we need to know the history, that whether it is the first onset atrial fibrillation that causing this heart failure problem, or it is an existing atrial fibrillation, or it is a paroxysmal atrial fibrillation. So we need to know the history, and that can be, I think, easily found out. And second point is that if the patient is hemodynamically unstable, particularly the hypotension, then there's definitely an indication that on anticoagulation, provided it can be given, we stabilize the rhythm with cardioversions. So that we faster we can stabilize the rhythm, the faster we can resolve the heart failure. Provided that the attribution is clearly could be connected to the atrial fibrillation onset and the fast beat.
I have one question to Dr. Ritupana. We know that in congestive state, diuretics is the IV diuretic, especially is the mainstay of treatment, and sometimes overzealous diuresis is bad. So when we'll call it a day in the ICCU and all, when the either intermittent or continuous Lasix is being given, when should we call it a day that will stop or reduce the dose of diuretics? Because you know that overzealous diuresis is bad and can cause hypotension and raise of creatinine.
Particularly in the ICU setting, so important is that the clinical findings of the patient. So you can definitely find out the hydration levels, the fluid status of the patient clinically, and the maintaining the saturations and particularly the hemodynamics parameters, like the patient is whether having the stable rhythm, the normal sinus rhythm, or the patient still having sinus tachycardia. So these are some of the parameters clinically can help. And also the bedside is very important to do echocardiography. We frequently do echocardiography to check for IVC. And IVC. Yes, IVC diameter and collapsibility is a very important factor. And sometimes just simply the leg rising can also help the size of the IVC, and then that also helps sometimes to find out the hydration state of the patients.
Exactly. What I feel with this.
Devashi, just
yes?
a minute. So actually, as far as this HFpEF is concerned, I don't think we use overzealous use of diuretics. The question arises when it's a case of high reduced ejection fraction. There, this diuretic becomes a sort of two-edged sword. If you don't give it, the patient is having congestions and all that. And if you give it in excess, there is the chance of deterioration. So sometimes you are caught in between two minds, what exactly to do to the patient or not. One thing you can do after you have reached a particular ceiling dose and you see that there is no extra diuresis, the diuresis is not increasing, then you can say that you can call it a day. However, there is no hard and fast rule regards that. But I think it's a very pertinent question that we often encounter in the ICCU. Those who are attending the patients, heart failure patients with reduced ejection fraction in the ICCU, they come back across such situations in which you are just pouring diuretics in the maximum dose and yet the patient is not improving.
And another one thing that I want to mention, that there is no mention of HbA1c or glycemic level in this patient. Just like that, but if they don't give this glycemic level and HbA1c, patient might have high blood sugar, and that can cause ketoacidosis, overt ketoacidosis, and acidosis that can add to the misery of the patient in the heart failure stage. So this is one thing. And all details of these diastolic parameters should have been given, as the speakers have mentioned, like LAVI as well as E by E prime ratio, and whether there is any increase in cardiac mass or LSIs like that.
Okay, I think we had an excellent discussion, and for the shortage of time, we can end up the session. And thanks to all the speakers and the audience. Okay,
Thank you,
and thanks,
everybody.
Shubhro. Okay, thank you.
Thank you for adhering to the exact time limit. It is just 12 o'clock and we will move on to our next session.